Dr. Eby, thank you so much. And again, I am not pulling prerogative. I think my hand was the first one up. That's a challenge for the rest of you. Dr. Eby, I'm going to start with you. Just a very quick summary of what I heard to lead to my question. I've only seen a few other systems like yours where they've cracked the nut of translating fee-for-service into global capitation payments. And as you said, it's usually by driving your cost down more than your revenue so that you actually have a margin that's related to that. You've increased your services and your team size while reducing your panel size, I think, to get what Toyin was alluding to of being able to have fidelity with what you're not only promising but delivering on without leveraging the professionalism of your workforce, which is what produces a lot of burnout when you don't have that kind of support for fidelity. And I'm sure Kelly would love to translate this to the Ohio model and the national pediatric network too. The question that I'm driving towards is coming back to Toyin. Toyin, how have you been able to do similar things? I really appreciated your description, but can you give us more depth of how you've been able to build your model to produce fidelity? Do we lose Toyin?
I'm not sure she's rejoined. I know she had to step away.
Oh, sorry, I missed that. Well, sorry about that. I wouldn't have driven straight to Toyin if that was the case. Kelly, well, I guess my question, please. And then I'd like to give that question to Kelly, what he sees here as a potential to model for them. Please, Doug.
Oh, sorry, I thought you were going to Kelly. No, I just in somewhat response to that, I think that as you were summarizing our story, a lot of the criticism people get, why doesn't everyone do what they've done in this organization, in South Central Foundation? Well, because it's daunting. It's a complete rethinking of the entire system. Specialists have to change. We use 30 to 40% less labs, less x-rays, less pharmaceuticals, because if you're in relationship with same-day access and trust, and you do lots of things virtually, people demand way less lab, pharmacy, and x-ray. Because if you have to take off of work and go across town and do this massive investment in a visit, then you darn well better do some labs and x-rays and give me some medications. I invested all this time and effort and energy. Instead, if it's a virtually present platform that never leaves your side and you can interact with it whenever you want to, then you're happy trying a little bit of at-home stuff or a little bit of time or using some advice for some self-care things instead of lab, x-ray, drug, because that's all modern medicine has time for, and frankly, it's all they know how to do anymore. And so the huge savings here are in reducing the cost, reducing the use of really expensive things, but also people look at us and say, Doug, most expensive primary care system in the world, look at all those people located in primary care. And the answer to that is 95% of them exist in the system. They're just separate islands, disassociated somewhere else with all these referrals and handoffs and all this discontinuity stuff instead of pulling them right into where they need to be to actively participate in the conversation in real time. So this is so much of the stuff I've heard all day today from other people doesn't question the fundamental paradigm of how the whole thing is, its philosophy and its structure. And if you change the premise of what you're trying to do and then consider all assets available to deliver what's needed and recenter around the people and how they live their lives, you got plenty of assets and you don't need as much revenue.
So Kelly, just quickly, is that something that could be replicated in Ohio for caring for children?
You're
on mute, I'm sorry. Okay.
Oh, can you hear me now? I have my phone on. Not hear that?
We can hear you.
Okay, I see thumbs up. Okay, so bottom line is we are trying to integrate from a different perspective. We are trying to convince the providers, the clinicians, that we can make their lives better through relationship by integrating our systems into theirs so they can be more present and we can bring our services there. We take our chronic care coordinators once a month out to some rural practices to do tube care and technology care for all the kids that are home on different things. We offer, I agree, it's drawing more expertise into the primary care setting. That's why we're using Project Echo to try to keep all the behavioral health care integrated within the practice. And the practitioners want to do that. They actually end up enjoying it once they feel they have the expertise, and once we pay them a little bit extra on the side to keep the patients there. So the system has to be an integrated system that can act from the top down, not from the practice level, but we're doing the same thing from the reverse end as a regionalized pediatric specialty system, pushing care out into the primary care practices.
So next we have up Chris Caller and then Linda.
Thank you. Dr. Eby, this is a question for you. Since you addressed my first one of if it's so great, why can't other folks do it? And what I hear is the challenge of changing the fundamental premise of what you guys are about, or what's the business that we're engaged in. So I'll go to my backup question, which was, what in the 25 years of work, what public policies have facilitated your work and hindered them? You know, what are the key public policies to focus on? Thanks.
Yeah, so let me just answer both. So as people hear about us and they come and visit us and look at us and hear our story, most specialists don't like us because we're completely threatening to how they do their business and to their massive incomes and all that kind of stuff, because they work on a salary. They do much more of their work virtually. They're supporters of the hub instead of their own separate islands optimizing their profits and life to their liking. So most specialists don't really like us. Pharmaceutical companies hate us. Labs and X-ray people and so forth don't like us. Hospitals don't like us. We haven't added a single hospital bed in 25 years because we just keep pulling work out and out and out. So we threaten profits for hospitals and threatens for pharmaceuticals and specialists and all of these people. And this is really, really hard. You have to question people's central paradigms and belief systems that they spent decades accumulating what they think is the truth. And we challenge that truth. So it's threatening to pretty much every dimension of modern medicine, which is the biggest reason why people don't just adopt it. But the community, people, patients, families, policymakers, payers, love us and think this is the way healthcare ought to be. We have a lot of fans in high places. Don Berwick calls this the future of modern medicine and all kinds of stuff if you're at a policy level and so forth. So from a public policy level, the problem is still the money, right? I mean, the way things are paid is increasingly fragmented and increasingly subject to diagnosis codes and procedure codes and so forth. So the best payer we have is the Indian Health Service, because we get money in essentially a block grant, and then we have to provide reports and accountability for what we've accomplished. And that's, of course, the perfect world for people like us, because we're actually beholden to the community. The community owns us. The community is extremely pissed off if we don't produce the goods. That's who holds us accountable. But the ability to be flexible with money and so forth, we just need to be held accountable, produce the clinical outcomes, produce the screening and prevention, produce the happiness and satisfaction, measure our readmission rates to the hospital, measure our hospital days per congestive heart failure person, measure our hemoglobin A1C control and so forth. But don't micromanage us. In healthcare, policy level, payer level, government, Medicare, Medicaid is just tighter and tighter, ratcheting down rules. Thou shalt do it this way, or you won't get our money. And then we'll send auditors in and audit the heck out of you to where you spend all your time chasing your tail, following rules, and getting audited, instead of being held accountable for outcomes and happiness and satisfaction and things like hospital rates and readmission rates and all of that sort of thing. Does that make sense? I mean, our experience of the last 10 years is just ratcheting down by payers, more and more audits. We just, we spend such massive time and energy being audited constantly, like every healthcare organization is. And then, we get glowing reports and they say, wow, you're amazing. And then the next month it's another cycle. I believe in coordinated single payer systems, but locally controlled, integrated, aligned delivery systems. And like I said, European countries and single-payer systems are actually the most interested in us. They tend to have great social support and great hospitals and specialists, but even all over Europe, they have wimpy primary care.
So are your feelings of accountability greater to your formal governance structure, or once you get past the patients, the individual patients, are your feelings of what's a stronger accountability mechanism? Your organization's governance, or some sort of a public government structure? What makes you jump higher?
Right. So we have a corporate governance, but they expect every single location we divide. So this kind of ties in with Toyin. By the way, I'm a massive fan of Toyin. I think she walks on water. We ought to just do what she says. But the fact that Toyin's whole approach is very place-based and community-based and community accountable, that's the same thing for us. So every village, every town, every community where we're active, we have an advisory council of very empowered, powerful, energized people. And our governance tells us those people must be happy and you must spend tons of time with them. If you get deeply into Baldrige quality worlds, by the way, whether it's manufacturing or government or healthcare or anything that Baldrige is applied to, they tell you that one of the most important things is obsession over the customer, obsession over the consumer. What do they want? What do they need? What's working for them? What's not working for them? We exist for their benefit. So our technical governance is then backed up by layers and layers of accountability to advisory councils and local people with power and importance and so forth. And then that's again compounded by the same thing as Toyin said. About 65% of our workforce are directly from the community by design. It used to be 15%. We're now at over 60% customer ownership employment in our system. So, and we tell our employees, we don't want any distance between your family and your loved ones and your work. In fact, that should be top of your mind as you're in your workplace. So truly consumer controlled, consumer staffed, consumer owned, consumer driven, consumer accountable at every level.
Great. Thank you very much.
So Linda, you're next.
Thank you for a fantastic panel. And I think the reason why we have this statement of task before us is that these three outstanding exemplars are what we are calling innovation versus standard practice. And so our charge as a committee is to glean what we can from the stories you've shared with us and look at what's preventing our country from moving forward. And so I'd like for each of the panelists to respond to that. But the other thing I wanted to have you respond to is, Doug, you talked a lot about training your workforce. And I wondered, a charge of this committee is to look at the workforce demands. And do any of the three of you have partnerships with educational institutions that are educating future providers to practice in the model that you want to hire them into? Or do you have to start from scratch? Do any of them come with you knowing this model and what you're doing? Or are you totally on your own to train the workforce? So two questions there.
Toyin, are you back?
I'm back. Sorry about that.
Go.
Sure. I'm happy to. So the first question on sort of, actually, do you mind, Linda? Just the first question was about kind of what are the barriers to us doing this more broadly?
Like if you if you had to name the top 2 or 3 barriers to why have other groups tried to replicate your model and it not worked? Like, what are the major, when we think about implementation, if we were to say, here are 3 models that we need to adopt across the United States, have you tried to do that? And what stops other communities from doing what you've done?
Yeah, I can give some thoughts. So on that, I think fee-for-service medicine has been continues to be just a major barrier, and a real challenge to overcome. Where most primary care is still delivered in a structure that is so closely tied to fee-for-service and so razor thin on the margin side that providers really struggle, I think, to invest in innovation, to radically transform, and then to move away from that place-based, volume-based model of care. So I think that's one. The second is, I think we're still pretty nascent. I love hearing from South Central Foundation in particular, because theirs is one of the most evolved and most tried and tested models out there. But many of us are still early on this journey. And so I think the one thing that we have learned is that there is no single playbook that people can take from one location and replicate elsewhere. And so part of the challenge is that I think, healthcare has a very, biopharmaceutical actually model for cognitive model for thinking about research and development and innovation. You test something in vitro, in vivo, it works on most people, and then you just disseminate. But humans are complex ecosystems, and they don't work that way. And what we're trying to do is build sustainable systems for massive scale behavior change for people with really heterogeneous needs in very different social settings. There is no single playbook that works. And so we have to rethink about our concept and our notion of implementation in this space much more around co-design. And co-design as a tool and as a set of tools and as a set of processes that enables communities to figure out what works for them, and then scaling and replicating that process. And so I think that there's a cognitive barrier there as well. And then finally, I do think that there's a workforce issue. I think that and that it's a workforce issue, and that concretely it is that we have too few of the right skill sets in the right humans doing the work in healthcare, and too many perhaps of others. So, but really what it is, it's about power and hierarchy and history, and the notion of the physician as the white-coated center of healthcare delivery, who acts effectively in isolation and who has ultimate autonomy and responsibility for having all the answers for all of the needs of the person in front of them, versus the notion that a largely not clinically trained, entirely not clinically trained, often with less formal education, team of community-based and field-based individuals may have something meaningful to offer to delivering health outcomes is a massive cultural shift in the way that we think about healthcare. And so we have a workforce problem in that the adoption of community health worker models, community health oriented models, and really the empowerment of those individuals to drive the change that they need to on par with the physicians is heretical to the way that we've set up the medical hierarchy. And humans don't give up power readily, and they have not been. There's been no incentive structure to force people to give up that power and to think about collaborative care in the way that we think it needs to happen. And so I think that's been a major barrier. And then it ties to your second question about kind of what are the workforce constraints. Then there, I think we're still we're still nowhere near where we need to be. And I think actually the hardest part has been, to my earlier point, has been retraining physicians and advanced practice clinicians to practice in a really different way when they come to work with us, to leave the white coat behind, to be on first name basis with everybody that they encounter, to listen to and value and appreciate the perspectives of others, to learn how to provide primary behavioral health and think that it's their job, to really, really learn to meet people with empathy and with respect on their own terms. It's tough. It's not innate to the way that we're trained to practice. And I don't think that, certainly my experience is not that medical education is churning out people like this in droves yet. So I think that there's a real thing on the formal medical education side that we need to solve for. And then honestly, on the community workforce side, Shreya is just the expert. I wouldn't really dare to even comment too much here. But there's a science to this, and I know she will tell you that. And that science in her world has been evolved and iterated over many years, and continues to be disseminated. I think we're really early in our understanding of what makes a really good community health worker as an industry, and the adoption of those best practices. But it's heartening to know that there are people who are taking this incredibly seriously and contributing to our understanding of that workforce in particular.
Right.
Thanks. So I have 4 people queued up. So just so you know, it's Tumani first, and then Shreya, Lucy, and Rebecca. Tumani, are you there?
Yeah, I am. I was waiting to see if the other panelists were going to answer Linda's question. But I can go to mine. So thank you for really, the 3 of you, for really a thought-provoking and I think really important discussion. I really appreciated it. My question is really about the care teams that each of you discussed, and kind of as we think about the implementation of integrated care teams and the different ways to do that. And I'm sure that one size won't fit all. But can you talk a little bit about sort of when you see that care team, and this I think applies to that diagram that Doug showed with the primary care team in the center, and then the circles going out. And then to Kelly's point about bringing the chronic care coordinator from the system into practices. So this idea of how the care team can be set up, this integrated team, is it in what ways or what types of team members need to be kind of at the practice and focused locally, versus when do you decide to have that from a system perspective, as in the model that you're discussing, Kelly? So it's I think that's kind of where I'm thinking is how does that implementation look versus locally and on the ground versus the services from a system-based integrated care team model.
So for us, it's quite a bit varied by the location, and particularly by agreements among the providers. So for example, some of the providers in the rural communities have agreed to send all their G-tube patients to one practice, because our G-tube coordinator goes down there once a month and meets with all the patients at the same time. Or in Ironton, we have a group of autism families that all come together in the evening when a practice is closed for common psychotherapy with the psychotherapist in Columbus who's on telemedicine. So practitioners have found innovative ways to either keep their offices open or partner or share patients in a way that as a network they all benefit from. And the same is true with our ECHO project, where they're developing local expertise on treatment of ADHD or treatment of hepatitis C. And so when that can happen, there can be coordination, but it doesn't happen within one person's office where you can say, this is the team. It happens as a group. A group of practices in an area will say, this is what we need for support, and how do we set this up? So it's a negotiation, but when you have good relationships over time, that's not hard to do.
So this, Doug, I will come back to that. I just want to support and echo what Toyin said first to the earlier question. She said it, I've said it, I just want to reemphasize it, that the single biggest barrier to doing this, to doing better things, is this massive loyalty and adherence to what she called the biopharmaceutical, what I call the medical model, and the disintegration of humanity into specialty and subspecialty and centers of excellence and all of that. It's ridiculous. If you listen to Toyin's model and our model, they're place-based, they're community-based, they're whole family and community structured. You're no longer the diabetic or the autistic or the whatever. You are a human that's in partnership with a bunch of people who bring a ton of expertise to try to help support you on that journey. So the core problem is what is pervasive in what's taught in every professional school that creates modern medical professionals. It's just wrong. It works for 1/3 of what we do, but it does not work for 2/3 of what we do. And let me just give you one very specific intervention we did that's been transformative. So the other thing Toyin mentioned was competence in other skill sets, and she's mentioned behavioral health and ability to connect and motivate people. So 10 years ago, we decided we needed to help our clinician mentors be better mentors. So we found this organization that did professional coaching of executives. They had never worked in healthcare, but they were very successful outside of healthcare. We brought them in. We've ended up working with them for a long time and then gradually bringing it in-house ourselves. So now all of our clinical people who are in any kind, well, just tons and tons of our people have gone through what we now call a coaching curriculum. And it was based off of this mentor stuff. And again, don't have time to go into all of this, very constrained time, but we've now put hundreds of our staff through this. And what they learn how to do is the actual technical skill set of really effective coaching. So I'll just take a doctor, tells me after this, they tell me, you know what, Doug, I now know how to mentor other doctors. I'm like, great, that was part of the purpose. And he says, but you know what? I'm also way better with my clinical team. I'm much less the doctor in control. I'm much more the facilitator, the partner, the team person. So I'm better with my clinical team. And he says, you know what? I also can manipulate my manager now because I know how to do that better. And I'm way better on the phone and in the exam room because it turns out 80% of primary care is really coaching, and really outstanding teaching and learning and skill development around coaching makes me a way better clinician. And by the way, my marriage is in much better shape. And those teenagers that live in my house, I actually know what to do with them now. And so it turns out it's a basic human skill, life set sort of thing that helps you in all dimensions of relating to other humans. But that is the core of what we do. We are a service industry providing a messy human interactive product. And the core of that is the messy human part. And yet the amount of training in all of our, whether it's a nurse training or a PA training or a pharmacist training or a doctor training, you get a little bit about behavioral health, but not very much. And you sure don't get deeply developed skills on coaching, advising, cheerleading, mentoring, which it turns out is the fundamental core of what primary care is, as we've heard from all speakers all day long today. And the sophistication and knowledge in that arena of our professionals is horrible, horrible. So yes, we do have to invest massively in retraining and reskilling our entire workforce for this work, which is sad, which then goes to your follow-up question around education and teaching in our professional schools and that kind of stuff. They're terrible. All they do is teach you the medical model. By the time you're out, you have a complete belief in that particular paradigm, which is full of assumptions and biases and prejudices that are not overt, but they're certainly baked in. And we have to undo all of that and then replace it with a whole nother different skill set. So there's huge work to be done there. We have concentrated on the last stage of training. So internships, fellowships, residencies, those kind of things as our best return on our investment, because then they come and work directly for us after completing those things. We were asked to write a white paper on the future of medical schools at one point, and the fact that our first sentence was that medical schools as they currently exist should be destroyed meant it didn't get a lot of wide play in academia. But I deeply believe that, this idea that orthopedic surgeons that replace knees need to spend 4 years in a common curriculum with psychiatrists who work with manic depressive disorders is insane. It's completely nuts. So it's just, everything's wrong with how we organize and select professionals and train professionals and so forth. So thank goodness they do have good medical diagnostic knowledge and skills, and they do learn how to use pharmaceuticals well, because that is important, but that is not the fundamental skill for primary care, which we have to completely retrain.
Great, so Shreya was next.
Thanks for these awesome presentations. It strikes me that we're hearing the same thing through different lenses and facets. So I would like to ask the speakers and also the group to crystallize what we think are the core components to some of these successful programs, recognizing that in reality across the United States, not everybody's going to get this perfectly right. There's going to be a spectrum from, you know, an ideal setting to, you know, the dysfunction that is our reality. What are, you know, 5 or 6 key things? Like what I'm hearing are, number one, very simple outcome metrics and not complicating that piece. Number 2, simple, somewhat global payment. Number 3, assigning one role per practice environment to sort of own the relationship. Number 4, a strategy for doing that, that is basically getting people's life story and turning that into tailored care plans. And number 5, nothing else, like no prior auths, no process metrics, no crap. So that's like my proposal for what our report should be. I don't know if I'm supposed to talk about that yet, but you know, we need to make this operational, and we have to design it for dysfunction. So what are the key things we can pull out from these, you know, models that are scalable?
Doug, I like your list. It's great. I like how you're distilling. I think you missed a huge one that at least Toyin and I would be obsessed about, and I think Christine would also be obsessed about, and that is that your workforce ought to look like the people you're trying to influence, and that ought to be maybe the number one demand. Because if we're in the business of influencing people to lead better and healthier lives, to take their medications, to do the difficult things that we ask them to do, the people best able to influence people to do that are people who are most like them. So for primary care, especially in particular, your workforce needs to be from the community you're trying to influence, needs to look like them, culture, ethnicity, beliefs, values, how they use words and communicate, because you have to have trust and influence if people are going to do the difficult work it takes to be healthier and change habits and all of that. So one of your top 10 must be your workforce has to be from and look like and be like the people you're trying to influence. Toyin, I think you'd agree?
And there's some irony that I missed that.
I don't know you well enough to comment on it, but I'm pretty strong in the opinion.
She lives and breathes it, so I know. Yes.
I like the rest of your list. I think the other one you kind of had on there, but maybe just add a little more. I think another common theme in places at work, and I think all 3 of us speakers right now, including the pediatric speaker, is the team idea, the team, and much less doctor centricity and so forth. Multi-skilled, multi-dimensional, multi-capable teams, and the behavioral health, coaching, partnering ability built into those teams. Yes?
Great, so we have Lucy and then Rebecca, and then we'll try to wrap it up and get to our public session.
So thank you all. My question is going to build on Shreya's question and the question that Linda asked earlier about implementation. And it seems to me that so much of what you're talking about is successful contextualization to your local communities. And I was hoping you could talk a little bit more about that from an implementation perspective. You know, rather than models that we're applying with fidelity, what are the principles for successful contextualization? And you've talked about co-design, local accountability, You've talked about retraining and reskilling of the workforce for coaching and teaming. You've talked about having a workforce that matches the community. But if you were going to take your care models and move them to a new community, what would be the most important things that you think that you should do, you know, aside from the ones that I've already highlighted that you mentioned?
I guess I'll start. The thing that I would say, and you know, one thing we haven't talked about this morning or this afternoon is actually the greed that's involved in medicine. And in particular, you know, I've presented our model to other children's hospitals around the country, almost all of them, as a matter of fact, individually, and many of their CEOs have toured our neighborhood, work on housing development and neighborhood employment, some other things. But several of them said, if we do this, we'll make, you know, we will be risking our income. And we are making so much money right now with these contracts, why would we want to change? When we go out to rural areas and say, you know, let us help you hire a lot more peer models and a lot more parent coaching and a lot more community health workers, the physicians say, am I still going to make as much money? Primary care docs included. That's the first question everybody asks. So I'm not saying we don't overcome that sometimes, but I think in the long run, we have to tell people physicians are not always going to make as much money as they do now. If we're going to be honest, there's not enough money in the system for doctors to give baby shots and crawl around the floor with babies and still make the amount of money that they do. So I tell people, we're not going to lie, we're going to tell you the truth. And some people, that upsets them. So I do agree, but our system to go in has to be able to say, what's the best possible way to do this in this community across all these providers? We have to share savings with child custody and child welfare to keep kids out of foster care. We have to share savings with the jail to make sure kids don't get in jail. So we sign contracts with all those agencies and say, we want to keep kids at home with their families in the right place, no matter who the provider is. And it may not be a physician all the time. So that's a challenge that we have to overcome. And so we tend to round up a lot of support in the community before we start with the physicians.
It's Doug. I would. Oh, no, go ahead, Toyin. Go.
Sure, I'll be really quick. The only thing I would add is the partnerships with community-based organizations. And you know, as you enter in a into a market, so as a healthcare provider, you enter into a community or market, people think about like, who am I going to refer my cardiology patients to? Who am I going to refer people for my joint replacements that need to get done? And so you build this network of like downstream providers. Rarely do we think about building high value referral relationships, true relationships with community-based organizations, where they have access to bidirectional information flow, where we're holding them accountable, where we are really, really partnering to make sure that our patients, our members, our communities get what they need. And so that's a key piece for us as we enter into a new community, is understanding who our partners are going to be on the community-based service delivery side and making sure that we value them in a relationship so that they can continue to sustain and do what they need to do.
Went to community partnerships. So I was going to go kind of the same place Toyin just went to: community partnerships, community platform, community accountability, and networking, and all of that kind of stuff. I think Kelly's got a good point on the money side. I said at the beginning, modern medicine is, our healthcare is messed up by two big things: how money is handled and the complete adherence and loyalty to the reductionistic mechanical medical model. They're both very, very true. In the U.S., most of the conversation has been around the money. So I tend to spend all my time talking about the over-reliance on the medical model because I think it's just as big and not as recognized. But the money is certainly a huge part of this. We view, our opinion, our community's opinion is pretty much all healthcare dollars are public dollars, because Medicaid and Medicare certainly are. Social Security is, disability money is, that's all public money. But even employer-paid health benefits we view as public money, because it's a big amount of money for the benefit of a large number of people who do not have individual choice. Therefore, it is a community asset delivered by an employer. And so if you add that in, you're at 95% of the money being a community asset. And if we start to demand that that be the case and get payment policies that treat it that way, then you start to be able to manage the money piece and you start to be able to manage the greed. So yes, the money part, I completely agree with Kelly. That has got to be fixed along with the other stuff. And then the other one thing I just want to, that's been mentioned just tangentially a couple times, but was really mentioned earlier was this business of transitions of care and the fact that all this fragmentation, which gets to the money piece, which is all this fragmentation, every different piece optimizing their bottom line and their own personal greedy profits instead of some kind of centralized control and coordination around money, referrals, and so forth. So the idea, I actually hate the word patient-centered. I hate the word co-creation. I hate the word medical home because of what they've all come to mean. And I'm happy to explain that if anybody wants to understand. But the idea that our institutions are someone's home is just offensive. It should be patient-driven and patient-controlled, not patient-centered. And co-creation usually means we let a couple of patients into our holy sanctuaries, but on our terms to talk about our structures, which is ridiculous. If you're really going to do co-creation, we have to go out into their environment, their lived reality, and adapt our services to their lived lives and what works for them. And so most of these terms they're headed the right direction, but they're little tiny incremental movements forward. So just the final point on transitions, if the primary care platform remains present in the person's life everywhere all the time, you reduce by like 80% the problems with transitions. But that means you have to continue to be present through specialists, through hospital, through nursing homes, through everything. You never are not part of the conversation. And that's the other piece, that's the other plank to the platform as you define it, is the always at your present, trusted expert, knowledgeable, partnering. But that doesn't have to be the doctor. That has to be the organization, but it has to be people they know. But it can be lay workers. It can be lots of different people. But that function has got to occur. And then just one final thing. We have a lot of pediatricians. I like pediatricians, but we've turned them into pretty much child experts supporting broader oriented generalists, community members, more whole person, whole family generalists. And just one final point there, one of the worst things we do on transition is we do all this work in primary care with people, and then they get pregnant. And what do? We send them to someone else for their pregnancy, just at the time they're actually making lifestyle decisions around diet and exercise and alcohol and so forth. And then the baby comes out, and then we do another transition. Well, that's dumb, because one of our biggest opportunities in modern life is pregnancy. People get excited about pregnancy and births and new babies. We should be leveraging the heck out of that, but as part of a lifelong journey, not as something separate. So when we talk about early childhood interventions, we go back to preconception and conception as the beginning of that conversation, not the day that they're born. And there's just stuff like that we do that we just take for granted in modern medicine that's just completely dumb if our job is to be the platform and relationship with people through a lifetime, and having maximum influence at opportunity times like pregnancy and birth and other exciting and difficult times in people's lives. So,
Doug, thank you. So we really literally only have 1 minute left, and Rebecca, I apologize. This means your question doesn't get into the conversation right now.